Irregular bones, like the vertebrae, display complex shapes. Their internal trabecular network distributes mechanical loads, this structure, leading to debilitating compression fractures.
Irregular bones have intricate, non-uniform shapes. They do not conform to traditional classifications. These structures represent highly specialized adaptations. They provide targeted protection.
Irregular bones have a spongy core. They are enclosed in a compact cortex. The outer layer is the periosteum. Inside, osteons form Haversian systems.
Haversian canals accommodate neurovascular bundles, supplying vital nutrients to bone cells. Osteocytes reside in cavities called lacunae, forming an interconnected mechanosensory network.
Bone tissue comes in two primary types. Compact bone is formed by repeating units called osteons. Cancellous bone is a lattice of trabecula. Together, they provide both strength and flexibility.
Let's compare bone densities. Compact bone is dense with low porosity. Spongy bone is a porous lattice. This highlights their density differences.
Compact bone has highly organized vascular architecture. It thrives within Haversian and Volkmann's canals. Cancellous bone relies on direct diffusion. Its vessels are dispersed within the marrow.
In compact bone, osteocytes are arranged concentrically. In cancellous bone, they are scattered irregularly within trabeculae. First, let's examine compact bone. Notice that marrow space here is minimal. Now, compare that to cancellous bone. Here, marrow spaces are highly abundant.
Let's compare compact and cancellous bone. Compact bone resists compression and shearing forces. Cancellous bone dampens impact and distributes loads.
Trabeculae adapt dynamically to physical forces. Regulated by osteoblasts and osteoclasts, resorb osteoid, forming temporary woven bone during repair.
Beneath the cortical shell, the cancellous bone interior is composed of trabeculae. The spaces between are filled with red bone marrow, the site for hematopoiesis, direct diffusion. This structure is replaced by lamellar bone. The spine consists of 33 vertebrae. It features cervical, thoracic, and lumbar regions. This axis provides weight-bearing and mobility.
A movable vertebra has a body and an arch. The arch is formed by pedicles and laminae. Together they form the vertebral foramen. Aligned, these form the protective spinal canal.
Extending from the vertebral arch are 7 processes. A single posterior spinous, 2 lateral transversus swirl facet joints, which guide and limit regional spinal movement. Anterior vertebral body. It functions as the weight-bearing part, moving back to the paired pedicles, out to the transverse processes, through the paired laminae, to the posterior spinous process. The cervical spine consists of 7 vertebrae. Each features a foramen transversarium for the vertebral artery. C1, the atlas, lacks a body, allowing the head to rotate. C7 is the vertebra prominence, a key landmark. Thoracic vertebrae increase in size from cephalad to caudad. Costal facets articulate with the ribs. Long, overlapping spinous processes restrict extension and stabilizes the chest. Lumbar spine, L1 to L5, featuring massive, kidney-shaped bodies, are designed to bear weight and absorb the stresses of lifting and carrying.
At the very base of the human spine lie the sacrum and the coccyx. The coccyx is also known as the tailbone, anchoring important muscles and ligaments.
The adult spine features 4 sagittal curvatures. Thoracic and sacral are primary curves. Cervical and lumbar are secondary curves. They are stabilized by major ligaments. The back muscles have 3 layers. Superficial muscles move the neck. Intermediate muscles maintain posture. Deep muscles stabilize the vertebrae. Arteries provide vascular supply. They supply the spinal canal.
Venous drainage occurs via radicular veins. They empty into the vertebral venous plexuses. These drain into the superior vena cava. The spinal cord runs down to thoracic region. The craniofacial skeleton consists of highly complex, irregular bones. They connect the neurocranium to the viscerocranium. These pathways protect nerves and vital organs. The sphenoid bone is a butterfly-shaped bone at the midline. It is divided into a body, lesser and greater wings. The sella turcica contains a depression for the pituitary gland.
Paired sphenoidal sinuses communicate with the nasal cavity, canals, and the superior orbital fissure. Greater wings contain the foramen and spinosum. Pterygoid processes serve as muscular attachment points.
The ethmoid bone is an unpaired, lightweight bone. It arises from the cartilaginous olfactory capsule. Caros type 3 presents the highest risk of perforation.
The uncinate process is a sickle-shaped piece of the ethmoid. It exhibits 3 major attachment variations. It influences drainage via the osteomedal complex.
The maxilla forms the upper jaw through midline fusion. It features frontal, zygomatic, and alveolar processes. The palatine process forms the hard palate. Its body houses the large maxillary sinus.
The zygomatic bone is the paired cheekbone. It has 4 processes. The temporal process forms the zygomatic arch. It displays sutural variants, including a bipartite morphology. The mid-lateral surface contains the zygomaticofacial foramen. This opening is highly variable and can be double or absent. The blood supply to the bone is codominant, form anastomoses to vascularize its body. The mandible is the strongest irregular bone of the face. The hyoid supports the pharynx and tongue. The pelvic pubis, ilium, and ischium protect organs. Auditory ossicles transmit sound to the inner ear.
The sphenoid bone features the optic canal. It transmits the optic nerve and ophthalmic artery. Compression here leads to severe visual acuity loss, red desaturation, and loss of pupillary light reflex.
The superior orbital fissure is a critical opening in the sphenoid bone. It transmits cranial nerves 3, 4, V1, and 6. Injury can lead to ptosis and ophthalmoplegia. The sphenoid bone features the foramen rotundum. It transmits the maxillary nerve. Compression here causes mid-face numbness, leading to sensory loss in the cheek and upper lip.
The sphenoid bone features the foramen ovale. It transmits the mandibular nerve. Compression leads to jaw deviation. It also causes sensory loss.
The sphenoid bone contains the foramen spinosum. It transmits the middle meningeal artery. Trauma here causes an epidural hematoma. This leads to severe intracranial hemorrhage. The ethmoid bone contains the olfactory foramina. These openings transmit olfactory nerve filaments. Compression or injury leads to anosmia. It can also cause cerebrospinal fluid rhinorrhea. Located in the maxilla, the infraorbital foramen transmits the infraorbital nerve and vessels. Injury leads to sensory loss in the lower eyelid, nose, cheek, and upper lip.
Highlighting the zygomatic bone. The zygomaticofacial nerve and vessels emerge, supplying sensation to the cheek. Injury causes sensory loss.
The vertical buttresses maintain facial height. Horizontal buttresses act as cross members. They stabilize the face in anteroposterior and transverse planes. Let's analyze the nasal bones. This area has a low fracture threshold. Failure occurs at 25 to 75 pounds. Front impacts lead to comminution. The frontal bone requires 800 to 1,600 pounds of force to fracture. High-energy traumatic impacts frequently involve severe cranial vault fractures. This simulation displays a distributed facial load. The fracture threshold exceeds 3,000 pounds. The skeleton remains intact but transmits shock to the brain. When loads exceed these thresholds, predictable facial fractures occur. ZMC fractures are a separation along its 4 principal suture lines.
Masseter traction can displace a fractured zygoma. Impinging on the mandible, this restricts movement, causing trismus. Orbital wall fractures increase volume, causing double vision.
Naso-orbito-ethmoid, or NOE fractures, occur from high-energy blunt impact to the nasal bridge. Forces transmit posterior, resulting in a saddle nose deformity. Crucially, this disrupts the medial canthal tendon. Disruption of this tendon allows the eyelids to shift laterally. NOE fractures can tear the closely associated dural membrane. This tear can result in a cerebrospinal fluid leak, predisposing the patient to meningitis.
Mandibular fractures are highly common. They are classified as favorable or unfavorable. Muscle forces can pull the segment, resulting in displacement.
Conduct a comprehensive facial examination. Orbitals are involved in most facial fractures. High-resolution CT is the imaging standard of choice. Systems map buttresses to identify fixation sites.
Irregular bones are susceptible to metabolic diseases. This leads to the thinning and fragmentation of the trabecular plates.
When vertical forces exceed bone strength, the vertebra collapses. These fractures often occur during routine daily activities. Many progress silently, discovered only during imaging. Multiple compression fractures can cause a progressive loss of height. This deformity can lead to decreased pulmonary function. Retroprojected fragments compress the spinal cord. Imaging confirms the fracture.
MRI is best for acute fractures. CT checks fragments in the canal. Management includes bracing and therapy. Vertebroplasty uses cement to stabilize. Kyphoplasty restores height with a balloon.
Neoplastic and inflammatory diseases affect the skull. Chronic ethmoid inflammation can cause osteitis. Prevalence can be as high as 64%. Secondary invasion is more common.
Fibrous dysplasia replaces bone with fibrous tissue. It shows ground glass opacities on CT. It causes orbital dysplasia and proptosis. Hemangiomas show thickened trabecular patterns. Errors in development can arise in utero. In vactral association, spinal defects are common. They affect 60 to 80% of individuals. Spina bifida is a neural tube defect.
EEA uses natural gateways to the skull base. It allows surgeons to repair leaks without disfigurement. Irregular bones compromise between lightness and protection. This supports hematopoiesis. Variations balance weight-bearing and flexibility. Buttresses distribute loads, protecting the brain and eyes. When external forces exceed thresholds, predict complexes. High-resolution CT with 3D reconstructions remains the gold standard for evaluating maxillofacial trauma.
Progressive trabecular bone loss weakens irregular vertebral bodies. Modern augmentation procedures offer reliable options to stabilize fractures.
This website makes learning so easy. I found all my resources here. This website makes learning so easy. I found all my resources here.